Hi everybody, today is Sunday, 29th of March 2020, and welcome to the London Dental Academy. This seminar is within a series of seminars during the crisis of COVID-19. So first of all, let me welcome you to the first seminar, which will be talking about the management of dental trauma in primary and secondary care settings. Before I start, let me just introduce you to this type of disease. As you can see, it's quite nasty disease called COVID-19, which is coronavirus disease, which was diagnosed in the Wuhan province in China back in 2019. Unfortunately, this disease has quickly spread all over the world, as you can see, and now most of the spread in Europe and the United States. This disease, just like a short history of this disease, is similar from the same family like SARS and MERS, the swine flu. It has got small diameter, about 120 nanometer in diameter, and also it consists of its genome consists of single strand of positive sense RNA. Unfortunately, this type of disease normally attacks the respiratory cells and the lungs, forcing the cells to replicate its DNA in multiple times, and that would cause most of the time pneumonia and severe respiratory disease, which could result in death, unfortunately. The disease normally starts within a few days after being infected with some fever, dry cough, shortness of breath, fatigue. Not necessarily all these symptoms together, but some of the symptoms, sometimes all the symptoms. It depends on the age, depends on the medical conditions of the host, and also depends on the immune response of the patient. So far, unfortunately, we have got almost 680,000 people infected. The death rate as today, statistics shows about 32,169 deaths, and almost 150,000 people recovered. From the local figure, as you can see, in the UK, we have got almost 20,000 people infected, death almost 1,235 today, and we have got about 216 new deaths just for today. So the disease is spreading quite quickly, it's quite serious. So we need to be aware of the consequence of this disease and how to deal with disease as healthcare professionals in dentistry and the wide spectrum of the healthcare provision. From our point of view, what we need to do and how to deal with this disease, there are few measures, and I think that I divided these into two categories or three categories. The first category is how to protect ourselves. So first of all, I think we need to be aware whether we are, especially for those who are delivering service at the moment with the primary or secondary care, whether we are positive or negative. So we need to expedite the process of testing, and I think the government in the UK has launched a program recently to test most healthcare professionals and to protect, of course, the healthcare professionals themselves and the patients. Most important thing for the patients, because once you get in touch with the patients, then there's a high likelihood that the patients get infected and get disease as well. When we do any sort of aerosol generating procedures, especially for those working in special centers and hospitals, in some countries where they don't have any sort of protection, then it's quite important to protect ourselves. The FPP3 respirator type of mask is quite important. They call it N95 in the States. These are some sort of industrial type face mask which should be used on all procedures with generating aerosols. For the public as well, I think it's quite important as well to protect themselves, if possible, by normal masks, especially those potentially are infected and those who might be at the risk of infection as well. So FPP3 is for all procedures generating aerosols. For non-generating aerosols, then it could be for people working in hospitals, not working with patient infected in normal environment like wards, outpatients, even general practices. Then there is no need to wear these masks. Normal masks should be fine. But again, we have to take all the precautions and protective measures in order to protect ourselves and our patients and our families. Social distancing has to be observed even for us during our work in the practice in the hospitals. If we are not doing any work, then staying at home is the best way, if not being deployed to any of the healthcare facilities being set up here in the UK or worldwide. Second thing to observe is to protect our patients. And I think testing ourselves is quite important, because if we are positive, then we have to stop work, self-isolate. If not, or if we are negative or not quite sure, then we have, I think, and this is the guidance from the UK government and also different governments. As far as I'm aware, the United States as well stopped all routine procedures and treatments, and all those potentially infected, symptomatic or asymptomatic, are being treated or triaged within designated centers, which are well equipped, and also the people working there are well protected, hopefully. I think the third thing which we need to look at as well, how to protect our communities, families, and the public in general, and that by spreading the message about the seriousness of the disease, and not to be complacent about the fact that this disease is spreading very quickly. And as you can see today, we have got over 30,000 deaths, almost 700,000 people infected worldwide. In the UK, we have almost 1,200 people, the death toll so far, and almost 20,000 people infected. It's spreading very quickly, it's very seriously, and I think we should be on the front line in terms of getting the message across to our communities. We need also to be, in fact, able to help our communities by spreading the messages through the social media and our websites, if you've got any websites, by putting some messages, even simple messages about self-distancing, not to go out unless it's been necessary to a doctor or work, or doing something really urgent or very important. And exercise, single exercise a day is quite reasonable. More than becomes less reasonable. So these are the things which we need to look at during the crisis. I very much hope, and the science community, the lab and researchers working day and night to find a solution for this disease, and hopefully that will be, hopefully a vaccination or treatment will be hopefully reached within a few months' time as we expected. But I think the worst case scenario, we have to prepare ourselves, and we have to embrace for the worst, and most likely things won't be get back to normal to the end of the year. So we need to be patient, we need to persevere with all the measures, and we need to protect ourselves, families, communities, and our patients most importantly. Let's go back again to our topic about dentoalveolar trauma. Today we will be talking about dental trauma, etiology, classification, and management with the primary care setting in our dental practices, and how can we manage such patients. As you know, most of us, we coming across such cases, whether acute cases or chronic cases, in the form of abscesses, chronic apical periodontitis or lesions, some infections, some discoloration, in cases where there are some underlying pathology but patients not aware of. From my point of view, in our hospital in Portsmouth, Queen Alexandra Hospital, we deal with acute and chronic cases. We have got a restorative dentistry unit where we have got the facilities to do all the possible treatment in terms of the acute, seeing people in the A&E or seeing them on outpatient at some stage to do some root canal treatments, or if extractions needed, replacements with bridges, implants, whatever the indications are for such patients. So we are almost covering all the domains of restorative and oral surgery in terms of management of dental trauma in general. So let's start with the aims and objectives of this seminar or this webinar. So first of all, we will be looking at what are the issues and the classification, and we get insight into the Copenhagen guide for dental trauma. The second thing is to look into the management and also how to develop evidence-based knowledge in clinical management of dental trauma. What are the measures we should take to understand the role of endodontics in saving traumatized teeth, and
mechanical
and also
is those that
demonstrate
involve
the role of dental implants in replacing traumatized teeth. So, as you can see, there is a panoramic view here for a patient who sustained a maxillofacial trauma, ended up with a fracture of the mandible. And there is angle fracture and also parasymphyseal region. And we can see some IMF wiring as well. Most likely, you wouldn't see such complications in dental practice. This is a hospital type service. However, in dental practice, most likely you will end up with seeing such cases. As you can see, there is a dental trauma, laceration of soft tissues, and some luxation along with extrusion, intrusion of some of these teeth. So these type of trauma you might come across, especially when you work in small towns or villages. If you work in big cities, most likely these will end up with A&E to be triaged and treated after that. So why is it important to treat traumatized teeth? What are the consequences of trauma? Actually, as trauma to any sort of tooth structure could result on one of these complications or consequences, or all of them together. First of all, discoloration. The traumatized teeth, especially in babies, normally get very dark quite quickly. The loss of vitality, especially with avulsion of closed apices, you might end up with loss of vitality, dead teeth, and also inflammatory resorption is quite important thing to know about trauma. Might result and develop some lesions around the surrounding structure of the roots, and malpositioning of the tooth if it's not being repositioned or corrected, and also loss of tooth tissues like fracture of enamel, dentine, and so on and so forth. So let's break down these things and look into this case or some cases by one by one. This is a 19-year-old gentleman I saw about 10 years ago at King's College Hospital. He had a trauma in the front teeth. Actually, he hit a lamp post at night, resulted in avulsion of the upper left one. And look what happened to the upper right one. This patient had a root fracture on the cervical region or the area of the root and on the coronal region, and this tooth was deemed to be not treatable or savable. Therefore, we had to extract this tooth, and again, after the extraction is a simple, straightforward solution, but sometimes quite difficult when you have that limited space, midline shifting to restore this space, and we did that time simple solution with some resin bond bridges. Such solution could be simple, straightforward. If it's acute case, is not very if it's a chronic case, if it's not very acute case. And this is the, luckily enough, as you can see, the height ratio of these crowns is not correct because he has got limited space in the mesial space, horizontal space. Therefore, having a low lip line for such patients is quite good news. As you can see, there is a metal as well showing there. This is very limited, but this is quite important to have replacement for these missing teeth with a provision of 2 resin bond bridges. So what's the prevalence of traumatized teeth or dental trauma in general? Normally is about 5% of all other injuries and trauma in the body. A quarter of the school children will experience some dental trauma during their schooling period. 1/3 of the adults will experience dental trauma as well during the permanent dentition when they are age 19 or under. And luxation is the most common dental trauma type of manifestation in primary dentition, and crown fracture is the most common in complication in permanent dentition. So we have to recognize here, normally in children and in deciduous dentition, we have a very soft supporting structure, so the luxation is likely to happen, while as in adult patients, we have got very hard bone, then the fracture and the impact of the trauma would cause some fracture, which is not a bad thing to happen, especially this would dissipate the forces and probably, hopefully, will prevent further damage, especially in the radical structure in terms of root fracture or in terms of avulsion or intrusion or extrusion. So what's the frequency of dental trauma in general? As you can see here from this graph, the least common complication is intrusion, and the most common complication of dental trauma is concussion. However, the most serious complication is avulsion, which is about less than 10%, as you can see, of all types of dental trauma. And we did some study actually in Hampshire ourselves in our hospital to see what sort of referrals we get from our local communities and what sort of the complications we might get. In Hampshire, it's quite a big area. We have got almost a population of 1 million people. And the audit which we did in the hospital showed that we received trauma by about less than, as you can see here, 20% of our care, of all our referred cases. The most common, I think, referrals we get is the oncology, because we are DGH hospital, and also hypodontia, almost 45%, tooth surface loss about 40%, and endodontics, as you can see.
I'm watching a webinar.
But most of the time, we will end up doing some endodontic treatment for traumatized teeth. So if we look at the types of this chart being taken from the International Association of Dental Trauma and showing all type of trauma which might come across, and I would like to share with you some of these pictures. As you can see, people still coming through, sorry about this. So hopefully, as you can see here, we have got the concussion, subluxation, extrusion, lateral luxation, intrusion, avulsion, infarction, and we have got some fractured of enamel dentine, complicated, uncomplicated, and crown root fracture, complicated, non-complicated, and root fracture as well. As you can see, what are the prognostic factors for long-term outcomes and also for long-term consequences of dental trauma? The most important thing is the severity of the injury itself, if it's mild or moderate or severe injury. The second thing is the age of the patient or root development in general, whether it's open apex or closed apex. And last thing is the timing of the treatment. The sooner the treatment takes place, the better the outcome, and also the root development, the more open apex, the better chance of revascularization and healing of our lesions. And the delaying the treatment is not in the best interest of the patients in general. As you can see, I think this, the International Dental Trauma Guide, which is developed in Copenhagen, based on about 2,200 cases or teeth on almost 1,300 patients, all treated between 1970s and 90s. So we have got almost 20 years of track records of dental trauma about the consequences, how do they develop dental trauma, and how do they treat them, and what are the consequences of such. So we'll discuss each one in details, but just to give you an idea how they divided these groups. They divide them in terms of tooth displacement, whether there is displacement from the socket or there is no displacement. If there is no displacement, is there any loosening or there is no loosening? If there is no loosening, it could be like some sort of concussion, and highly unlikely there is any sort of fracture. And if there is any loosening, then there is some sort of what we call it subluxation. Again, with subluxation, we don't normally do any sort of treatment. So with no displacement, highly unlikely we'll do any sort of intervention. But if there is any sort of displacement, then we will end up in the intrusion, extrusion, luxation, and avulsion, and also could be like a root fracture or a alveolar bone fracture. So whenever we have got displacement of the tooth, then we will suspect that something needs to be done and need to be looked after, unless if it's just simple intrusion or subluxation, and then we might be able to deal with it. But most likely, most of the time, we will end up with extrusion, intrusion, root fracture, or lateral luxation, as you can see. So we'll go through these cases one by one, or three scenarios one by one, and how can we manage these cases in the primary care setting. So what are the key factors in the management of traumatized teeth? The first thing is we have to preserve the pulp vitality, which whenever we can. Permanent teeth where we have got open apices to ensure the development of the teeth all the time. We have to also to make sure that the immature teeth or open apices also give them the healing capacity if possible, and that by stabilizing the teeth if they are displaced, position them, protect them from any further movement or further injuries, and giving the patient sometimes bite guard or monitoring the patients on a regular basis to make sure that there is no sort of worsening of the dental trauma in such group of such patients. The prognosis of avulsed teeth is largely dependent on two things: the vitality of the periodontal ligaments and the maturity of the root itself. So the more we have got healthy PDL tissues, the more we have got open apices and revascularization, the better the chances of saving these teeth whenever is possible. So let's move. I think we need to close the room. I can't get any more people coming through. So let's see some of the scenarios which could happen. I mean, some of these injuries, most of the injuries happening in young patients, especially having like on a skateboard or having some sort of outdoor sports. And just I will watch this video with you guys just to share how sometimes persistent young people to do their hobbies, especially in outdoors and indoors, as you can see. So as you can see, this young child trying to skateboard, as you can see, first time, second time, he couldn't make it, third time, and those most of the dental injuries coming through the doors is with people, as you can see, to complete their and to finish what they're doing. And as you can see here, it's quite serious injuries. And actually some of the patients coming through the doors to the hospital, they have got some video recordings when they done these things at home or at school or at the playgrounds. As you can see, quite serious injuries. I'm so sorry to share these cases with you, but that's most of the time what's happening. And actually some of these shared with myself. Now, let's just go for the most simple type of dental trauma we might come across, which is the infraction. Normally it appears as a crack within the enamel, and normally crack is incomplete fracture, meaning that there is one end which is not very visible and the other end is completely invisible. And also when you take radiographs or x-rays, you don't normally see any sort of abnormalities at all. It's, as you can see, it's quite limited to the enamel, does not propagate within the dentinal tissue or the pulpal tissues. The tooth is asymptomatic, patient does not have any symptoms, and the testing normally is positive or is normal. And normally this situation doesn't need any sort of intervention, and patient will continue their root development as normal without any problems. Enamel fracture, quite common as you can see, and that could be restored by either putting the fractured or the chipped enamel back if we can find it, and that would be through bonding, etching, and then some bond, and then bond the fractured part to back where it belongs. Even if it does not fit completely, we can fill the gap with some composite or some resin if it's very, very thin. If the fragment is available, as I mentioned, if it's not available, then what we can do is we can restore it with some composite, as you can sometimes do for any normal type of restoration. Normally, the root development will take place normally without any complications, no mobility at all, and the sensitivity or sensibility testing is normal as usual. There is no problem at all. But we have to look for the fragments. Most of the time, these fragments could go inside the soft tissues. Therefore, I would suggest that we take some x-rays for the soft tissues if possible. Here we have got a fracture of the enamel and dentine together. We call it uncomplicated fracture because it does not involve the pulp. And this is a patient I saw a few years ago back, I think in 2007, 2008, where we restored this tooth just with composite, as you can see. Sometimes you don't have any sort of wax ups, or you can do it on the day by freehand technique. If you fancy thing, you can always do wax ups or mock-ups or any sort of treatment. But most of the time, patients coming through the doors, they want their teeth restored. And I think these quite simple to restore and to deal with it on the spot. So normally there is complete fracture of enamel dentine. If the fragment available, as again, you can bond it by etching, bonding, and putting the fractured parts together. If it's not available, then we have to restore it, and we can restore it with some resin composite. Normally, the root would develop without any complications, especially in the mature teeth. Normal mobility and the sensitivity testing is positive. However, that does not mean we don't take X-rays. Take X-rays to rule out any sort of root fracture, to rule out any alveolar bone fracture, and also we have to test the vitality of these teeth in all cases, and that's what I do normally in my practice. So I don't rely on that just that the patient is asymptomatic or rely on the patient's symptoms. So always we have to keep looking for tooth fragments, whether they are, and some people bring these fragments, especially for school kids where they have got the fracture, they can allocate these fractures, fractured or chipped teeth. We can always wash them, etch, as you can see, bond them to the teeth or the substrate back with the protein procedures as we do with etching, bonding, and resin composite. If it's not available, then we have to do in such cases just restore the teeth with protein resin composite restorations. What about if the tooth is complicated crown fracture? Then the pulp is exposed, as you can see in such cases. And most of the cases coming, as you can see, with fracture, acute problem where patients actually have got some severe symptoms, they have got problems, and we need to look after these people immediately and keep a close eye on their treatments. I think the mainstay treatment for such cases is Cvek pulpotomy, which is successful in most of the cases, almost 90% or higher. And in these cases, as you can see, we have got exposed pulp. And this technique is quite, we are lucky enough that the pulpal tissue, especially in young patients, open apices, immature teeth, we have got high healing capacity due to the fact we have got a lot of stem cells. But we need to remove the pulpal tissues, the dead tissues, and getting to some live bleeding and live tissues in order to get the best possible capacity of healing and develop some sort of dental bridge on the top of it. To do so, we need, as we remove part of the pulp, whether with some excavators or some rose head on slow hand piece. And then once we get the bleeding, we seal it with setting calcium hydroxide, a layer of GIC if you want to, and then composite restoration on the top, and followed by monitoring. Most of the studies confirm that up to 9 days delay may have minimal effect on Cvek pulpotomy or the healing capacity, and the outcome is not affected by the exposure if it's less than 4 millimeter. As long as it's smaller size, then the healing capacity is quite high, and also we have better prognosis and healing when we have got open apices in most cases. So let's move to the second. Now we have got complicated crown, and we have got sometimes, as you can, root crown fracture, but sometimes it's subgingival or supragingival. On 70% of cases, when we have got root treated teeth, the fracture would be subgingival. In 30%, it's supragingival. It's the other way around. When you have got vital teeth, most likely the fracture will take place supragingival. But when we have got a subgingival complicated crown root fracture is very, I would say, serious issue, and also we have got very poor prognosis because the restoration of these is not predictable, difficult to get access to where the bevel of the fracture. In these cases, most of the time we need to do some gingivectomies or some lengthening surgeries in order to expose the fractured part and also to teeth predictably. So the emergency treatment would be by either removal of the fragment or by bonding it. Most of the time I would remove it because bonding it is not predictable, especially with subgingival fractures. So if on the spot we can't do it, you can keep it for later on, but I think most of the time it's highly unlikely you will be able to bond it back again if it's the fracture line located quite deep subgingival. And again, it depends on the vitality of the teeth, if the teeth are already root canal treated or not. If not, then most likely we would need root canal treatment if we decide to save these teeth. Sometimes it's not possible to save these teeth if the fracture is quite big and there is substantial exposure of the pulp, or if it's root treated already, I think highly unlikely we'll be able to save these teeth, especially when they have got serious type of fracture. So let's move to the root fracture itself. The root fracture, it depends on the location of the fracture. Could be in the coronal third, could be in the mid third, could be in the apical third. Actually, this patient was a 17-year-old boy, was playing karate, ended up with fracturing the upper right tooth. Funny enough that this, when he presented to me, he was asymptomatic, and it was routine screening, and I found out through incidentally that this tooth has fractured. As you can see, it was a vital tooth, no complication, no mobility at all for this young boy. Just actually keeping an eye on this tooth for the time being. I saw this patient almost 2 years ago, no further complication, no need for root canal treatment or even to have any sort of a splinting for this tooth. Now, when you have got root fracture, as you can see here, is located in the mid-third of the root and here in the apical third. I think the worst prognosis teeth is when you have got the coronal third fracture. The mid-third is better, but it's not much better. But the best case scenario when you have got the apical third fracture, which is sometimes the tooth is vital, you don't have any complication, and just keep an eye on the tooth. Now, if the tooth is not vital, you will end up just having from root canal treatment to be finished at the fracture line without any further type of treatment needed. So let's, again, we will going to the root fracture. Most of the time we need 2 x-rays. Parallax is used to rule out any root fracture in the adjacent teeth, and also to see, sometimes it's not visible on plain radiographs, so we need parallax view to rule out any root fracture or the adjacent teeth. Most of the time I would examine 3 to 3 on such cases to rule out any sort of fracture on the adjacent teeth as well. Now, when we confirm that there is root fracture, what should we do? First of all, if it's acute case coming through the doors, immediately then we have to do something about it. We have to reposition the tooth or the fractured bit. We have to take x-ray to make sure the repositioning is the right, correct position. And we stabilize it normally with flexible splint for 4 weeks. And monitor the teeth. If it's immature, there is a likelihood the sensitivity might be fine. If not, then root canal treatment would be warranted, and that should be as soon as possible. Now, if we getting into the stage of we have got different type of injury along with the root fracture. Without root fracture, we have got, as you can see, the buccal plate fracture, and we have got some sort of luxation, and we call it that, as you can see, lateral luxation. But most of the time with luxation, we see either extrusion or intrusion. Like in this case here we have luxation, but there is intrusion as well. Here you can see luxation with extrusion. So sometimes you won't end up with only one scenario, you might end up with few scenarios at the same time. And as you can see here, we've got uncomplicated fracture, fracture enamel, dentine, chipped of enamel, as you can see, the bite all coming on the upper right one. So trauma is not like straightforward. We have to, and this, as you can see, a little bit of healing and scarring and some sort of scabs on the lip, meaning that the trauma took place a few days ago. And that most of the time happening when the patients are being seen in the A&E, like for example on Friday evening, then coming to you the following week or the week after. And then these cases, it's quite too late sometimes to treat such cases, end up unfortunately in losing teeth, losing vitality, and also it becomes, the triage becomes difficult, and most of the time we will end up with some extracting some of the teeth or doing root canal treatment because the window of healing has lapsed, unfortunately. So now let's, this is the lateral luxation. We have to reposition with the aid of Triad. Triad is like a resin-based material. I use it a lot, especially with linking some components for maxillofacial work, but I use it as well for linking teeth together, especially above or mobile teeth, or we can use composite. We make sure that the positioning state is quite correct with some pre-epical radiographs. I would say make sure the radiographs are in the right position, because sometimes if you don't, especially in such cases, people in pain, numb the patient up, reposition it in the right place, stabilize it with composite or Triad, take the x-ray, make sure that the patient is pain-free in order to control the type of movement you do on the tooth. Stabilize it with flexible splint for 2 weeks. Well, this is like, could be used as stainless steel wire for orthodontics 0.018, and monitor for the coming few weeks. When the tooth becomes non-vital necrotic, then root canal treatment. Again, the likelihood of this tooth to heal and to preserve its vitality is quite high when the tooth is, or the root is immature, or the patient is young and still with the root development window, which is we have got the revascularization process is quite possible for open cases. Now, if we got some sort of avulsion of the upper right one, as you can see, intrusion and lateral luxation of the upper left one. This case for 20-year-old young gentleman I treated about 10 years ago. He presented me like this, and I suspected that there's something going on with the upper left one. I think most of the cases you will end up with a situation like this, and we should not be looking at the gap and replacement, but rather looking actively on these teeth to see what sort of treatment, what sort of management being considered before our management to take place. So the first thing, I need to take x-rays to see whether there is root canal treatment or not, there is any root resorption or not, and then I will take further measures in order to treat such patients. Now, if you have got any sort of intrusion, then we have to allow for eruption to take place. If no movement within a few weeks' time, then we have to initiate some orthodontic repositioning, and if it's quite big distance, about 7 millimeter or further, then surgical repositioning might be required. And the way we do it is numbing the patient up, getting some forceps, and try to pull the crown down and split with wire splint. Now, if the apex is closed, most likely we will end up with necrotic pulp, and root canal treatment will be needed after that. In my experience, most of the cases with these, you will end up with some root resorption. The prognosis is not great. Root resorption, if it's replacement resorption, they might take a while before replacing the tooth. Is inflammatory, then I think it's highly unlikely the tooth will heal. But again, we have to observe closely. We have to monitor the patient. As I mentioned, if it's closed apex, the tooth might erupt over time, but it's not full eruption as we expect sometimes. You have got like a couple of millimeters, but does not mean that you will go to the occlusal plane as it should be. If no movement, then again, repositioning has to be surgically or orthodontically. As I mentioned, orthodontically got limitation, less than 7 millimeters, even 4 or 5 millimeters sometimes is very difficult to extrude the tooth. But again, we have to consult or to talk to our orthodontic colleagues in order to see whether they can help us or not. When it becomes necrotic, then root canal treatment is considered, repositioning and stabilizing the teeth. And when we have got stabilization, again, we have to use flexible wires and splinting for 4 weeks. Intrusion is quite serious, like a root fracture or like alveolar bone fracture. So we have got a few scenarios. We have to splint the teeth for 4 weeks, intrusion, alveolar bone fracture, and root fracture. The rest, I think most likely 2 weeks should be enough. When we have got, this is the case, we have got intrusion for the upper left one, as you can see, resorption on the roots, as you can see, the tooth left without, as you can see, the GP without any dentinal tissues around it, and the upper left one has avulsed on the spot. So we'll end up with some tooth movement of the canine, which gave us some sort of limited space for the upper left 1 and 2 resorption, which luckily enough it was replacement resorption. There is no inflammation or infection around the root. And as you can see, because it was intrusion, and then we had to do some sort of lengthening of the crown with provision of resin composite in order to get it aesthetically acceptable to the patient. Of course, the decision that time was to do some replacement for upper left 1 and 2. Therefore, it was mandatory to take some CBCT 3D imaging in order to see whether there is any bone loss. As you can see, there is significant bone loss at the buccal plate. There is, as you can see, big bone loss there. And as you can see, the section here, there is a big dip in the buccal plate. So most likely with most of the time, we have got concavity in the buccal plate, we have got bone loss, and we have got area which we need to graft or to do some sort of GBR at the time of placement or implant placement. So this is the case where we have got the upper left 1 and 2, and this is after taking the teeth out. As you can see, the buccal plate completely lost. There is a big concavity, and replacing these teeth might be challenging if we consider dental implants. But if we're talking about Rosemonde bridges, then that might be necessary. As you can see, there is a sort of fracture of enamel as well. So restoring the fracture, doing Rosemonde bridge from the upper right 1 and then from the upper left 3 to restore or replace upper left 1 and 2. At the beginning, we have to start with some, we call it a partial denture. It's like a prototype for our future treatment to see whether we need soft tissue enhancement or not, whether we need any sort of bone grafting or not. And this part of acrylic is quite informative from our long-term management of such trauma. Trauma always associated with loss of soft hard tissues and concavities in these regions, especially in the anterior region. So we had to do, as you can see, 2 implants in the region because we have got limited space. The angulation of the implant might be tricky. One is parallel to the canine, the other one to the upper right 1. Again, TDR is quite important in such cases because it's we have a loss of soft and hard tissue, and we have to make sure that the restoration is quite aesthetically pleasing for the patient. So not only restoring teeth or replacing teeth, but also we have to replace hard and soft tissues. Extrusion is one of the, as you can see, the tooth is out of the socket in the vertical axis position and sometimes interferes with the occlusion. So what we're gonna do, if it's acute case, straight away we have to do reposition it, check repositioning with X-ray, stabilize it with composite, with triad, and again, soft for 2 weeks. Monitor. If the root and the apex are closed, most likely we need the provision of root canal treatment. If it's open, then there is a likelihood of revascularization of the vitality might be maintained. But I think in my opinion, most cases like this, you will end up with having root canal treatments, especially with extrusion and intrusion, especially in the adult patients. This picture taken from Dental Trauma UK, and this is simple message for the public about when they come across, especially in the schools, playgrounds, outdoors activities, even for parents, when you have got a tooth coming out of the mouth as a result of trauma, then the best way to pick it from the crown, clean it with water, rinse it, try not to destroy the PDL cells. As I say here, lick it, for example, or keep it in saliva if possible. If not, then in the milk. Stick it back again in the right position where you find the gap. If it doesn't go straight in, fully in the right position, then it doesn't matter. The most important thing, we have to keep in the socket, and that we call it the extra. We have to reduce the extra alveolar time. We have to reduce this gap in order to maintain the vitality of the PDL tissues and the stem cells, as you can see. And then after that, ask the patient to bite on something, keep the area clean as much as you can, straight to the dentist in order to stabilize it, splint it, and then monitor after that. In kids, most of the time, we will get good healing after. In adults, most likely we would need some root canal treatment. If it's baby tooth, don't do anything, and I think the message is not to insert it, just to keep it out, because that might affect the buds of the adult teeth. So what we can do for management of avulsed teeth, first of all, we have to clean the teeth, as I mentioned, hold it from the crown, straight in the socket as soon as possible. If we have got any complication of the adjacent teeth to restore them, we can do them later. Soft tissue laceration, we have to suture them. Once we verify the position, we have to stabilize it with either with putty or with composite, make sure it holds in place, and then we have to have splint, flexible splint for 2 weeks. As I mentioned before, if the root is closed, then root canal treatment would follow. If not, then we will have to monitor as long as possible, especially for flexibility. If it's if the apex is closed, I would suggest to do root canal treatment as soon as possible, sooner than later, in order to get the best possible. The problem here, if you don't do the root canal treatment early, and hoping that the tooth will hopefully revascularize, and the tooth might, the sensitivity or the vitality of the tooth will be maintained, is highly unlikely to happen. We'll end up with resorption, root resorption, and we'll end up with very, very poor prognosis. However, if we do the root canal treatment quite early, then the likelihood of survival for this tooth in general is quite good and reasonable. I'll just share with you this case, which acute case, came to me for treatment, actually referred from one of my colleagues in the hospital to treat upper left 2, as you can see. But when presented to me in the beginning was quite normal, and then the following appointment, I observed swelling on the buccal sulcus of the upper left 2, as you can see. And as you can see, this is the case. It was a big lump. As you can see, there is a significant amount of pus coming. But if you look at the video here, you can see like the swelling most likely is a relation to the upper left 1. But in fact, the infection, I will show you the X-ray, and you will see that the infection is taking place on the upper left 2. But when you look at the dentition, it's quite healthy. There is no problem at all, no decay, no periodontal disease, no fracture, nothing at all. So sometimes we have to think out of the box and to think why this happened and why this lesion was there in the first instance, because this is a young patient, I think age 17 or less than 17, 16 at that time. Once we, as you can see, drain it, first of all, of course, you give the patient some local anesthetic, make sure it's numb, and you do establish incision, and then you start draining. And with your artery clips, try to dissect the soft tissue in order to go remove all the barrier of the soft tissue and to get the best possible drain for this case. So it's quite dramatic to see people from simple, big infection from simple problems. As you can see, this is the upper left 2. And when I looked at the tooth, straight away came to my mind, can you see this quite big infection actually, and with a big swelling? But diagnosis was for this tooth, as you can see, like the small tooth inside tooth, we call it density intake, was all is class 2. And then I had to do root canal treatment. But as you can see, I'll show you X-ray later. This is straight after treatment, few weeks, very nice healing. And the latest 6 months or 1 year, as you can see, bony infill with complete healing of. Just to let you know that we do some training at Queen Alexandra Hospital in Portsmouth. We do monthly seminars, all free for our colleagues and dentists. You are more than welcome to join us. During this period, I will attend to invite some of my colleagues to give some seminars, and hopefully next week we'll have a seminar of acute management of pulpitis by one of our local endodontists. So we'll give you some good news, hopefully within the next few days. In the meantime as well, we have got some courses in restorative endodontics and implants at the London Dental Academy. Please feel free to email me personally if you are interested. And also we're traveling overseas to Qatar and to UAE as well in the near future to do such courses. So let's start with this case, just to give you some insight of what types or what sorts of trauma might come through the doors on a daily basis or regular basis. This patient presented to me with discoloration and a denture replacing upper left 1 and discoloration of the upper right 1. But as you can see, there is a big restoration there of composite. So this tooth had sustained trauma, ended up with discoloration, and unfortunately, as you can see, ended up with having root canal treatment left without being treated properly or being just partially treated. For me, this is a partial treatment than full treatment, because you can see this discoloration is quite significant and we have to do something about it. Now, if I ask the audience today, most of you, probably some of you say, I'll crown this tooth, some others say, I will do veneer. But I think the most important thing here to maintain and to preserve the tooth tissue as much as we can. Therefore, doing what we call it inside-outside bleaching is a technique where we remove the GP and the up to the cemento enamel junction, and then we evacuate, I would say, the pulp chamber, keep it open all the time, and start injecting carbamide peroxide at 10% over 2-3 days time, over every 3 to 4 hours. And that would get to this stage as soon as possible. As you can see, from that shade to this day shade, it took me just 48 hours to 72 hours in order to get the bleaching and then restoring the gap of the upper left one with resin on the bridge, using the upper left two as a point. Straightforward, simple treatment, but made big difference for such young patient. And no need for implants, as you can see. If I consider implant, then bone grafting will be warranted in this area due to the buccal cavity. Now, other cases, I showed this case early to the presentation. Avulsed upper right one, intruded, as you can see, subluxated upper left one. When we took X-ray, we found some root resorption, and as you can see, complete, as you can see, lateral luxation out of the sockets, I think. But the good news here, we preserve some of the bone in this area should we plan to put some implants, because this tooth luxated laterally, buccally, and maintained the which were in the position we want the implants to be. And as you can see, but we have got limited space for in the mesiodistal, and that might limit our options in terms of replacement, or the aesthetic treatment might not be. So the first line of treatment, as you can see, is to do what we call a partial denture in order to get a diagnostically right in terms of height-width ratio to see the patient's perception, patient gauge, the patient's response for treatment, and then we will go for further treatment later on. So in this case, we took some X-rays, as you can see, but luckily, as you can see, when we did the X-ray, we did not find any inflammation. Is just there is some resorption, but it's replacement resorption, meaning that there is some sort of loss of dentinal tissues or root tissues, but there is no inflammation. There is no loss of the pristine bone in the area. Therefore, if we decided to replace the upper right one or upper right one, upper left one, then we will end up with hopefully no inflammation in the area or bone loss. But if you look at the X-ray, we have got massive incisive canal. We have to consider and we have to take it into account when we come to the replacement, as you can see. So the first thing, I decided to do immediate partial denture, extraction of the upper left. As you can see, there is resorption, as I mentioned before, and this is part of the GP might be left. As you can see, there is some sort of bevel, could be resorption, could be small root left there, but I would not chase it in such a situation because it would cause further damage of the bony tissues and of the socket. So it's better to take it out, clean the socket, let it heal, and revisit it after a while. But I think CBCT will be required in this, especially with the case we have got significant, as you can see, quite obvious on the X-rays that we have got a significant size of the incisive canal, which might prohibit us from doing any sort of surgery in this area like implants placement, unless we do some grafting for the incisive canal with GBR or some bios in this area and restore it. But again, that depends on the patient, depends on the indication. So we decided to do implants at 3 months later stage. As you can see, 2 implants being placed. As you can see, the incisive canal is being filled with some bone substitute, and as you can see, the position of the implants quite good. Just simple trabecular incision along with the crystal incision, no releasing flap to maintain the papillae and to prevent any sort of recession of the adjacent teeth, and 2 implants. And this is the stage 2 where we took the impression at the same time. And we decided to do 2 provisional crowns, as you can see. These are the composite crowns, temporary cylinders replacing upper right one, upper left one. As you can see, there is some soft tissue gap there. I think it's quite difficult when you've got 2 implants adjacent to each other. But again, most of the time, as you can see, these are the provisional crowns. Highly unlikely I'll be able to develop any soft tissues or papilla infill between these 2 teeth. Therefore, we decided to metal ceramic linked crown on multi-unit or uni-abutment level. And by this type of strategy, we'll be able to replace the pink and white equally and in a nice way. These are the crowns on the models. As you can see, splinted metal ceramic at abutment level. And these after being fitted, as you can see. Can you see on this X-ray here, we have got some GP actually showing on the apex of the implant here on the upper left one. And you can see it's quite significant size of the incisive canal. But in these cases, that should not cause any problem or concerns because it's inert material within this area. Class 2 Div 1 patient, a 17-year-old patient. When I treated him, when he was referred to me, actually was 14-year-old. fractured enamel, as you can see in the X-ray. Unfortunately, we have got big lesion, and this is called the inflammatory resorption. And the mouth completely eaten, as the tooth is completely eaten, as you can see, and we have got a lot of resorption on the upper right one. Poor root canal treatment on the upper left one. We have got the tooth as well. The upper right too has got loss of vitality. So the treatment here has to be staged, has to be taken into account the age of the patient through development. We have got complete closure of the root apices on these teeth, so highly unlikely we'll be able to do any sort of revascularization or any fancy treatment. So we decided to treat it into stages. First of all, I decided to treat the upper right two, as you can see, with some root canal treatment. Hopefully that would help me to heal the lesion. Keep the upper right one as long as possible in order to maintain it and getting space maintenance for the time being. And when the patient is ready, by the age of 17 or 18, then, as you can see, the resorption getting worse over time. But by that time, I decided to do root canal treatment for the upper left one. Hopefully we get better prognosis of this tooth and not to include it within the context of our management plan. And as you can see, after treating the upper right two, upper left one, we extracted the upper right one at the right time. And this is quite important to extract at the right time rather than the beginning of the treatment. The patient is 14. Now the patient is getting 18, 19. I know that there is deficiency in the bone. I know that there is some buccal deficiency and buccal concavity. But again, it's quite important to maintain, as you can see, the area very well and to make sure that we are prepared for such eventuality by having some GBR or some block bone grafts in this area. So I decided to do a placement of the implants at the same time to do GBR for the buccal concavity using BIOS and BioGuide, as you can see, and I use it normally double layer. But in some cases, I don't use it on double layer from one side. I'll use it from the plate and from the buccal to cover it from either side. And that would help me to stabilize the bone grafting as long as possible. As you can see, this from the buccal, this from the plateau, and the overlap on the area. Wait, 2 weeks healing, as you can see, nice. Regeneration of soft tissues. The profile of the soft tissue is quite healthy, it's quite normal, as you can see, but these cases don't feel that this is a dehiscence or problem. Rather, I will keep it as long as possible and to maintain it and to observe. And as you can see, 3 months later, very nice soft tissue healing. We did stage 2 on impression for temporary crown. And it's a very nice keratinized soft tissue surrounding the implants as well, the upper right one. This is before, and this is after. As you can see, the implants placement of upper right one in right position is good position. It's quite apically positioned in order to get very nice emergence profile. And again, we decided, as you can see, this is before a root resorption, big lesion around the upper right 1 and 2, completely healed, both root canal treated and implants has been placed. And then this is the provisional, as you can see, crown in place, replacing upper right 1. So this is before and after. The patient had very bad oral hygiene, unfortunately, in the beginning. We have to encourage some decalcification from the orthodontist treatment as well. But as you can see, this is the provisional crown in situ following the treatment, upper right 2, upper left 1 in very good shape following the root canal treatment, no discoloration as such. Again, we have got some cases to discuss here when we have got complete root closure and closed apices. It's quite difficult for such cases in order to treat them on the spot, rather than we have to use either revascularization technique or we have, especially in the open apices, but if it's closed apis, we have to use some sort of bioactive material as a plug to plug the tooth. And here we use MTA, as you can see, plug the apex and then backfill it with GP and then restoration with composite. The timing of the treatment, most of the time I've got infection, I would do probably 2-stage treatment. I would not do 2-visit the type of treatment. I would not do it in single visit. Dress it with calcium hydroxide, wait to get some sort of healing, and then, as you can see, the apical block using MTA or biodentine, any sort of material, and then backfilling and restoration with composite or GIC. Now, other case, as you can see here, the upper right 1, as you can see, open apex as well. In a young patient, I think was 15 or 16, discolored tooth. Again, we use the same strategy using a MTA plug, or I think, yes, MTA plug. And nowadays, we try to reduce MTA these days because of the discoloration problem. Backfill with some GP and then GIC and composite. So decision making is quite complicated, it's quite important in order to optimize our treatment, but we need some evidence in order to back up our treatment. We need to have research-based evidence. We have to have the clinical expertise, and also the patient's values, patient's expectations of the treatment is quite important in order to get the right treatment. I'll share with you this case. Upper right 2 fractured, came to us. Actually, the trauma was involving upper right 1 and 2. The upper right one was treated by the dentist. I will show you in a minute with a metal strand crown and a post. This was left for me to sort out. So it's questionable whether it's, as you look at the x-ray and look at the remaining tooth tissue, whether it's restorable or not restorable, but looking at the tooth and looking at the quality and the quantity of tooth tissue looks like restorable. And based on the criteria we normally use, we have to have at least 3 millimeters of feral tooth tissues before going for treatment or deciding on restorability. So I decided to do root canal treatment of upper right 2. As you can see, a GP, a master apical point, and during the stage of obturation and have the down packing, we decided to do the fiber post. As you can see, this is quite important, not to leave the tooth long, but rather than to do the post straight away if you going for restoring the tooth, rather than doing the root canal treatment and back again to evacuate the root canal and do the taking impression for indirect post. I would always go for direct post in such situation and using fiber reinforced composite, as you can see inside the root canal. And then we build the tooth with direct composite stage by just putting some blobs and building the whole tooth, preparing the tooth for a direct composite. First of all, direct composite restoration of crown, and then preparing for indirect restoration or indirect crown. As you can see here, the tooth tissue is left quite healthy. We have got nice margins, so the restoration would be predictable in such a situation when we coming across such restorations. Now, we have got more challenging cases when we have got root fractures. We have got subgingival, as I mentioned before. 70% of the cases, root canal treated teeth, we have got subgingival fractures. Then we have to consider in these cases doing what we do, root lengthening or gingivectomies. As you can see here, we did some gingivectomies and we prepared the teeth for 2 direct fiber posts, as you can see. And these are parapost type materials used long time ago. Nowadays we use Everstick materials, quite easy to mold, easy to fit and to get the right build-ups at the same time. Here sometimes it's about tricky to get the right shape of the post, getting the right material, right bonding stuff. But again, I think it's quite important to restore the teeth as soon as possible. The earlier, the better, rather than leave them for a long time. Then it comes to the stage, the teeth might fracture or it might be very difficult to restore, and you will get the soft tissue to grow on the top of these teeth. Isolation is quite important. Use a rubber dam. Using the right bonding technique for these teeth is quite important. I would use always the 4th generation is possible, etch, prime, bond, and resin composite on the top of that, as you can see. And then finishing, polishing is quite important with the right stuff. I'm using here the Soflex disc and the Pogo tips along with the enhanced materials. And again, I mean, sometimes you get some decent result with some indirect or restoration, but direct restoration always is the first line of treatment. So if we want to revisit this, and doing indirect restoration is always possible. Just to cover the bonding stuff, we have got 4th, 5th, 6th, 7th generation. The gold standard, the 4th generation, especially in big restorations. If we're doing any sort of post-cementation or any sort of a dentine bonding stuff, we use 6th generation. In this case, 6 and 7, we don't have etching stage. We have just the prime and bond and straight into restoration, because the polymer is acidic by its own. It's not, doesn't need any etching. If we bond it to enamel on such toothware case, then the 4th generation is quite strong and is the gold standard. We etch, we do the prime, and then we do the bond. Sometimes the prime itself coming into bottles, and then the bond after that by using the adhesive resin and then the composite. But as I mentioned, 6th generation is quite reliable, especially when you are bonding to dentine and to healthy dentine, most likely like cavities, so on and so forth. So with the direct restoration for endodontically treated teeth, for traumatized teeth, the root canal treatment generally reduces the stiffness of the teeth by 5%. If one of the margin ridges is lost, then the stiffness of the tooth will be reduced by 16%. If two margin ridges are lost, then the stiffness of the tooth is reduced by 63%. And the resin bonded materials and composite would normally recover most of the stiffness of the tooth, as some studies shows, and some people indicating that, especially the studies done by Manucci and the clinical trial back 2002, what they found that the composite restoration along with the fiber post is equivalent to full cuspal coverage. In my opinion, even if you do a sort of fiber post with direct composite restoration, I would still suggest doing full cuspal coverage with indirect restoration to protect the teeth from further deterioration or fracture. As you can see, the brittleness of the tooth will increase, and the tooth will be subject to fracture by 6 times, especially for endodontal teeth, if we don't crown it or do full cuspal coverage on it. The failure rate for fiber posts is between 2% to 18%. It's quite a big difference. It depends on the materials used and the protocols used, and also the people using these materials. The risk of fracture or failure decrease as long as we have got over 50% of tooth tissue, especially in the anterior teeth, and 2 to 3 walls in the posterior teeth. So less than 2 to 3 walls in the posterior teeth is quite difficult. And the area of dentistry, which is quite clear and always difficult to judge, is the restorability of teeth. Most of the time, people going too safe and then sacrificing the teeth, taking the teeth out, and they saying it's not restorable. Sometimes you decide it's restorable, but I find it very difficult to restore, which would take you a long, long time, and a lot of I would say procedures, especially with root crown lengthening, and we do gingivectomies, we do to restore teeth. So restorability is not always straightforward. The shape of the post is not very relevant, and the material is quite important. The anterior, always we will go for fiber posts, and I would use the molded Everstick type fibers if possible. I would avoid the parapost because normally they're coming in a shape which might undermine the tooth structure or the root structure, and that could potentially cause fractures or cracks. Fiber posts covered with crowns, I think, reduced the failure rate by 6%. I think this is quite evident that the crown teeth, survivability of crown teeth after root crown teeth is about 80%, 82% by small studies, coming down to 70% if it's not being crowned, although they're being restored with fiber posts and direct composite restoration. Sometimes with the trauma cases like this case, you've got 2 discolored lateral incisors. Unfortunately, this lady had orthognathic surgery back in the 1970s. We end up with very short shoots on the upper lateral incisors. Sustained trauma ended up with losing both lateral incisors. Replacement, not necessarily always by bridges or implants. A direct bridges using fiber reinforced composite bridges might be feasible. As you can see here, we extract. Sometimes you have to put the rubber down to isolate the area very well because there is bleeding, and if there is bleeding, the bonding will not be predictable. Fibers will be stacked buccally and palatally and into the gap between the teeth, and then the pontics build up into layers and finished and polished, as you can see. I will show you in a minute. And we'll give you a reasonable, I would say, transitional type restoration where we have got 2 like laterals be restored with direct fiber reinforced composite restoration. So it's not always we have to replace teeth with partial dentures. With some people can't wait, especially with the extractions and immediate replacement, unless we have got partial dentures. But imagine you have got always something to offer the patient, and with laterals like this with composite, they will work very well for a few years' time. But again, we prepare the patient for definitive restoration with metal ceramic definitive resin bond bridges or implants. Again, I'll show you with this case. This patient presents to me, young lady presents with missing upright one with nothing in situ, as you can see, not replaced with partial denture or resin bond bridge, and the decision was to replace it with a direct composite, fiber reinforced composite restoration. So again, we pumice the tooth just to clean the surface for bonding the upper left one, etching, and then stacking our fibers directly on the palatal on the buccal surface. And then, as you can see, the core of the upper right one is being established, and then the composite on the top of that to make sure that we have got the right restoration, as you can see. And it's very decent, I say, treatment outcome for such patient and for such immediate replacement on the spot. It's just like 45 minutes to 1 hour is not, it's not bad at all. Discolored upper right one trauma case, failed RCT. I took X-ray. In these cases, rather than doing for inside-outside procedure straight away, I decided to do root canal treatment first. Secure the tooth first. Make sure that the root canal treatment and the seal is quite good. And then we do the bleaching after that. And if you want to do any sort of composite or ceramic after that. But even if you can see with thin gingival biotype, the shine through effect even take place through the gums, especially if the discoloration, as you can see, of the root itself. So discoloration not only for the crown, it could also affect the roots, especially with this type of thin tissue biotype, and that with recession, of course, that will shine through, will give you some grayish type color. So we need to be wary about these situations. We need to inform the patient and concern the patient when it comes to bleaching or in terms of indirect or direct restoration, because the outcome might not be 100% right for the patient. As you can see here, we have got this tooth, which is the lower right two lesion. Again, before doing any sort of judgment or treatment, then we have to go ahead with some full investigation, including periapical radiographs, testing the vitality or sensitivity of the adjacent teeth. And I would say for the most sensitive test in these cases is endofrost, and rather than electric pulp test, and then doing root canal treatment. And that will give you very quick sort of type of healing, as you can see after finishing the completion of the root canal treatment. Imagine these cases coming to adult patient being overlooked for many, many years because the patient did not notice or did not observe any symptoms, and the dentist did not pay attention for these cases. Well, we discovered these cases, like another case here, being subtreated on 2 central incisors. When I decided to do on the lower right one, I decided to do the treatment on the lower left one. I think when you have got any sort of poor root canal treatment, doing some treatment on the adjacent teeth is better to consider. Full comprehensive plan, doing 2 root canal treatments, obturation, as you can see, fill with composite and monitor, and that will give you pretty much a straight results of healing. This old lady presented with big lesion on the lower incisors, as you can see, big lesion. Canals are not very wide, as you can see, pretty much calcified. So the root canal treatment is not straightforward sometimes, especially in the apical region. Negotiation is required, time concentration is quite important, and root canal treatment will give you a very decent and outcome on the spot. Sometimes you get even more complex situation where you've got trauma on all anterior teeth, 4 teeth, as you can see with periapical lesions. Root canal treatment is, as you can see, it might not be the right treatment option for such patient. But in the transition, till we decide which teeth are viable, which teeth are not viable, then root canal treatment might be good, and also to generate some bone around the apices rather than going and extracting the teeth and leaving the defect, which might be problematic in the future when we decide to do some sort of implant treatments in this area. So root canal treatment, although I know that the prognosis of the lower left one, lower right one, quite, as you can see, dodgy, is not very secure for the long term. This might heal, but again, monitoring for long term is quite important. We coming some situation, we have got young patients, 11, 12, 9, 10-year-old boys coming with trauma, open apices. Again, I mean, these quite challenging to treat, especially young patients. Pediatric cases always difficult to manage in terms of numbing the patient, get them to sit on the chair, doing such long treatments. But again, is sometimes you will find the root canal system is quite clean, there is no separation, and therefore obturation with the provision of bioactive material like MTA or biodentine or any putty materials might fill the open apices, as you can see, and the backfill is quite straightforward. And again, I mean, some people suggesting doing dressing with non-setting calcium hydroxide for long periods of time. In my opinion, that will weaken the tooth tissues and not necessarily very productive. So here, either we do revascularization of the periapical tooth tissues with using the vascularization techniques, and revascularization technique is quite well known, but you need to have the right setting for that and the time to do it. If not, then doing, as you can see, MTA plug or biodentine plug and backfill it. The problem with that is, again, as a side effect of our treatment. Discoloration definitely will happen if we're using MTA. So we are now tending to stay away from MTA as much as we can. More complex, Volsi, 13-year-old, repositioned and planted. Unfortunately, this gentleman or this young boy did not have any sort of root canal treatment straight away, referred to us at later stage with 2 big lesions, and here I decided to preserve the teeth. Again, you have got two ways of managing this, either revascularization and monitoring, and hopefully you get some sort of apical seal in this area, and then that monitor for long term, and that revascularization will help with the healing process and also will help to maintain the vitality of the teeth. If not, then apical block using bioactive material like what I did here using MTA in the backfilling with composite. This gentleman did, this young boy did very well. Actually, he's 18-year-old, finished his orthodontic treatment with no complication, and the teeth are still in situ without having any further or significant resorption on these teeth. More complex situation like this, I think it's quite rare to see Deficient dentae in such massive size, as you can see on the upper right one, along with periapical lesion, unfortunately, like the one I showed you early on the upper left too. The management is not straightforward. Most of the time you need CBCT to identify the morphology of the root canal anatomy. And as you can see, the obturation, again, although is predictable, but I think needs a lot of technique, and technique sensitive, needs a lot of patience. And in terms of the cleaning and shaping of this root canal system, it's not straightforward. There is no type of any file or any instruments will go and clean the whole root canal system from inside. So there are some scenarios which is off textbook, and we have to adapt to these cases and use different techniques in order to clean and shape and obturate this root canal system with different type techniques which are not necessarily in the textbooks. Unfortunately, this is not the time to discuss these cases, but it's overall how to manage the trauma in general. This is the upper left one I showed you with the big abscess in the upper left one region. As you can see, this after the treatment 6 months later, complete healing of the area, no problem at all. And as you can see, the tooth is restored and functional. There is no need to consider extraction or replacement. So management of traumatized teeth, management of such congenital problems like in Deficient dentae or any sort of complications might not be necessarily difficult. As long as we have got treatment plan, we consider that we have got enough training to do such treatment. That's the most important thing. We need to understand, and we have got the knowledge, and we have got the understanding what's the protocol involved in treating such patients, and also we rely on evidence rather than on our success rates on particular region or particular part of the world. We have to read about the success rates of primary, secondary treatment, traumatized teeth. We have to read a lot about what are the success rate, for example, complete apex in avulsion, in luxation, in intrusion, extrusion, in order to make some sort of decision on such cases. And finally, we have to consider the financial cost for the patient or the healthcare system. Is it worth saving these teeth? If not savable, or if they are not savable, what are the strategic importance of saving these teeth for long term, and how we could manage such scenarios, especially with people coming at early stage when they are quite young, at the age of they are in the teenagers, and they are not suitable for any definitive type of treatment. And just to let you know that we have got some course in endodontics, in restorative and implants at the London Dental Academy in London, and we're doing some extending overseas as well, hopefully. But now our main concern is to get through the difficult time of the coronavirus, and hopefully the people all over the world will be recovering sometime soon from such shock to the actually this massive problem, which put us in very difficult situation. I think most of the world now in a lockdown period. We don't know where we're gonna go back to work. We don't know what's gonna happen tomorrow. So let's hope that something will happen, hopefully in terms of treatment, vaccination, and we need to stick together, and we need to have the positive attitudes, positive vibe among us, not to get scared from this type of problem, because I think what's coming ahead in the future might be more serious. Let's learn. We had the bird flu, we have got the swine flu, and we have got the corona flu or the coronavirus, which is within the same family. And I'm pretty sure, I'm positive that we will recover soon. But let's be prepared, and our preparedness will be based on the knowledge, based on the experience. It's not based on emotions only. So we need to get ourselves prepared for the future and how to defeat such enemies. I'd like to thank you. Now, before I finish, I'd like to open the door of discussions for 5